Assalamu alaikum. Greetings. मैं राजीव टंडन हूँ. I'm a professor and chair of psychiatry at Western Michigan University in the United States. I've been a practicing psychiatrist now for over 40 years. I did my initial medical school training at the All India Institute of Medical Sciences in New Delhi. And then I did my a residency at the National Institute of Mental Health and Neurosciences in Bangalore. And then I came to the United States almost 40 years ago, about 38 years ago. And I've been a practicing psychiatrist since then. My area of specialization has been schizophrenia. And I have about 400 peer reviewed scientific publications. I've been very active in a number of international scientific bodies. I'm the editor in chief of the Asian Journal of Psychiatry. And I was on the DSM 5 work group that worked on developing changes, criteria in our characterization, definition, and clinical treatment of schizophrenia spectrum and related psychotic disorders. And this is one of the things I would like to share with you over the next 30 minutes. What were some of the changes made? So now, although DSM 5 has been in existence for the last 7 years, it came out actually almost 8 years now. It came out in 2013. Are not fully aware of the important changes that were made and are not utilizing them in their clinical practice. And I want to share with you the highlights of those changes, the rationale, and most importantly, the clinical relevance and the important implications for helping each one of our patients as well as we can. So let's get on with the presentation. And before I go any further, I want to share with you my conflicts of interest. I don't have any financial conflicts of interest with regards to this presentation, but as I shared with you, I've been a practicing clinician for about the past 40 years. And as a physician, I have a bias, a clinical bias. I really like helping all my patients. I want to do everything I can to help them get better. And I like things presented to me in a very simple, straightforward manner, because any new information that you share with me, I want to make sure that it's applicable to my care of the next patient I see. But one of the challenges with a clinician bias is that the bias that I bring to my thinking is because I care so much about each patient and want to help them to the maximum extent possible, that I think everything that I'm doing is helping them. And sometimes it's not. Sometimes what I'm doing may actually be hurting them. And so that's a clinician bias, if you will, to be aware of, which is why in all aspects of medicine, we have investigations which which basically help inform this clinician bias, if you will, and allow us to make better clinical decisions. And I've been researching schizophrenia for about the past 35 years. And in the area of schizophrenia, my focus has been on the neurobiology of schizophrenia, the treatment, pharmacological treatment of schizophrenia, its characterization, the nosology of schizophrenia, and really the concept of schizophrenia itself. That's where most of my research has focused. And the last bias that I bring to bear on this, what I'm going to share with you, is, as I mentioned, I was a member of the DSM 5 work group on psychotic disorders. And this group was operational from 2006 to 2013 when DSM 5 was introduced. And we must have spent about 3,000 to 4,000 hours each one of us on this work group. And we weren't paid for any of this. It was uncompensated time. We worked very hard at thinking about what the challenges were in the characterization of schizophrenia, what changes were necessary, what the rationale was, what the effect, the implications of these changes on clinical practice might be. and what might be most useful from a clinical practice perspective. And so the bias that I might bring with regards to this is I think the work that we did had some value, is useful, is important. And so be aware. So I just wanted to bring that to your attention. What are we going to touch upon over the next 25 to 30 minutes? Well, you're all familiar with the clinical features of schizophrenia. So I'm not going to get into basics, if you will, with regard to the clinical features, etc., that you're familiar with. But I want to emphasize the key clinical aspects of the condition, which were relevant to how we define it. And then I'm going to share with you the key changes that were made in the definition and description, diagnostic criteria of schizophrenia, other psychotic disorders, and then most importantly, discuss with you why these changes were made, but what the clinical implication is, what the value is as a physician, as a treating psychiatrist, with regards to the changes made in terms of our ability to help our patients. And so as we get to why we want to make a correct diagnosis of schizophrenia, it's important to recognize what the implications of the diagnosis are and be aware of and avoid common mistakes that that are still being made. So let's get on with the presentation specifically. So what do we know about the basic nature of schizophrenia? This is something that we're all very familiar with, but I just want to start off with this basic set of information that we're all familiar with. So schizophrenia is a psychotic disorder which the psychotic symptoms generally begin in late adolescence to early adulthood, a little earlier in men than in women. And this is once the psychosis begins, the illness does not go away for more than 90% of people with the illness. There are a small percentage that do fully recover, but for the most part, it's a chronic, remitting and relapsing illness. And the remissions, when people are well, they're not completely well. So the remissions are generally incomplete. And this is an important aspect that we need to keep in mind, which is very relevant in terms of how we treat patients and what we need to be cognizant of. One fact about schizophrenia that we're aware of, but we really don't take to heart and really apply meaningfully, is the fact that schizophrenia is not just one syndrome. There are multiple psychopathological dimensions of schizophrenia: positive symptoms, negative symptoms, cognitive symptoms, mood symptoms, motor symptoms, thought organization symptoms. There are multiple psychopathological dimensions. And that's a very important aspect of schizophrenia that we've not really been able to fully incorporate into our thinking about persons with schizophrenia, and for that matter, other psychotic disorders as well. And lastly, schizophrenia doesn't look the same in all patients, all persons with schizophrenia. It varies a lot. One person with schizophrenia looks very different from another person with schizophrenia. There's extreme heterogeneity in terms of what symptoms are manifested and the course of illness, which makes individualization of treatment very, very, very important. And so how can we do it better? There are a couple, one of the remaining two facts that I want to kind of bring to your attention. We're aware of that persons with schizophrenia generally don't do very well. They are not as effective members of society. Less than 15% of them are fully employed and fully independent. But again, here, significant variation, significant range of how people do, ranging from complete recovery to being completely incapacitated. The last fact that I would say about schizophrenia is something that is under-recognized, and that's unfortunate, that persons with schizophrenia die early. there is a doubling of age standardized mortality. What do I mean by that? What does it mean? Well, basically, it means if compared to the general population, the best control for me is maybe a twin that I have, identical twin, 100% of genes we share, of course, the same parents, the same food, same upbringing. The only difference is I have schizophrenia and my twin does not have schizophrenia. And so, what does this mean? It means at the end of 10 years, no matter how old we are, I am twice as likely to be dead as my twin. That's what this means. Another way to think about it is on average, persons with schizophrenia live about 15 years, 12 to 15 years less than the general population. And if you think about any other condition in medicine, you'd start off with this when you talk about what is schizophrenia, it's a potentially fatal illness. That's the way you would start off by describing any other condition. But that's not how we tend to think about schizophrenia, but we need to be aware of that. So let's move from there to what the relevance of some of these clinical aspects are before we come to the changes in DSM-5. Why is it important to know that it's a remitting relapsing illness? Well, because relapses, bad things happen. And relapses are not uncommon at all in schizophrenia. Just showing you the rates of relapse, if you will, over time in persons after their first episode of schizophrenia. So very high likelihood of relapse. And when relapses happen, of course, patients are worse. They have to be re-hospitalized. There's a greater risk of suicide, a greater risk of violent behavior, and they get worse. But the other thing about relapses is not only do bad things happen in the short term, but there's something about psychosis that is toxic to the brain. So if you have untreated psychosis, particularly early stages of the illness, it damages the brain, untreated psychosis. So how do we know that? Well, after each episode of a relapse, psychotic relapse in schizophrenia in the first few years, when they get better, they're not as well as they were before the episode. Secondly, they take longer. With each episode, it takes longer for them to get better. Thirdly, the same treatment that was effective before the episode began, the psychotic relapse happened, may not work. You may need a higher dose of the medication, a different medication. So bottom line, it's important to be aware of this fact that relapses are common, and particularly in the early stages of the illness, relapse prevention, aggressive relapse prevention is a very important critical treatment goal. Now, obviously, relapse prevention longer term too is important because with each relapse, bad things can happen during the relapse. But no changes were made in the characterization of schizophrenia with regard to this particular issue. A big change that was made was in keeping with this understanding about schizophrenia, that schizophrenia is not one thing. There are multiple symptom dimensions of schizophrenia. And there are 6 different symptom dimensions of the illness. Positive symptoms, that's delusions, hallucinations, paranoia, suspiciousness. Negative symptoms, lack of motivation, lack of social drive, difficulty expressing yourself, emotional blunting, disorganization, both disorganization of thinking and disorganization of behavior, cognitive deficits. The average IQ of persons with schizophrenia is about 80 to 84. Broad impairment of neuropsychological functions, some more than others. Mood symptoms. Depression is so common and so severe in over half the patients with schizophrenia that but for the fact that they have schizophrenia, they would have received a diagnosis of major depressive disorder. So mood symptoms are a very important aspect of the illness. And then motor symptoms. Motor symptoms are present in about 40-50% of patients with schizophrenia. Now, the most extreme expression of the motor symptoms, of course, is catatonia. Now, why is this important? This fact that you've got these six different symptom dimensions. Well, it's important because one, there are different brain mechanisms, there are different circuitries that underlie these six symptom domains. Even more importantly, these symptom domains respond differently to treatment. So when you think about treatment, you think about antipsychotics. That's the mainstay in the treatment of schizophrenia or other psychotic disorders. Well, positive symptoms and disorganization respond pretty well. That's where antipsychotics are most effective. Negative symptoms, cognitive symptoms, antipsychotics don't do much at all. Mood symptoms, motor symptoms, antipsychotics can both help and hurt. So we use antipsychotics adjunctively to treat depression. On the other hand, antipsychotics cause neuroleptic dysphoria, which is depression. Motor symptoms, antipsychotics can treat catatonia, but then antipsychotics can also cause the worst kind of catatonia, neuroleptic malignant syndrome. So it's really important to keep this fact in mind that one essential characteristic of schizophrenia, and for that matter, other psychotic disorders as well, although not to the extent as you see in schizophrenia, one critical element is that there are six different symptom dimensions. And that has important implications, both in terms of pathophysiology, but even more importantly, in terms of how you want to individualize treatment. And to add to the importance of this fact, is that different patients with schizophrenia have different admixtures of these symptoms. And in the same patient with schizophrenia, at different points in their illness, they can have different admixtures. So this is a very important fact of schizophrenia. And in DSM-5, we basically had to address this in a significant way. So let me, we'll come back to this in terms of how it was addressed in DSM-5, but let me close out this discussion of the clinical elements of schizophrenia with its natural history. So for a long time, we have focused on this phase of schizophrenia. Once it begins, and then the progression, its chronicity. But actually, in the last 20 years, there has been greater emphasis paid here. Because one of the things that we have realized that although our treatments are effective, by the time patients come to us at this stage of the illness, they are, we can do important things to help them get better, but they still don't get very much, they don't get, we're not able to improve them to the extent that they can lead normal lives or virtually normal lives, if you will, for the most part. So over the last 20 years or so, there's been greater attention being paid to the pre-morbid and prodromal phase of schizophrenia. And there's a very important change that was made in the characterization of schizophrenia with regards to what we have learned. So this is the prodrome. When you think about the onset of schizophrenia, actually persons who go on to develop schizophrenia pre-morbidly, they show some deviation. They're shyer, they don't do quite as well at school, they don't relate as well to their peers, there are oddities. And then about 1 to 5 years before the onset of psychosis, which is when we say schizophrenia begins, actually 1 to 5 years prior to that, they show different symptoms, about 5 years on average. And this is average. This is not for every patient with schizophrenia. But on average, what you see is about on an average of 5 years prior, you begin to see some subtle cognitive impairments, lack of attention, difficulty learning. Then you begin to see mood symptoms, anxiety, uneasiness, and then you, along with negative symptoms, flattened affect, withdrawal, isolation, and then you see the functional impact of this in terms of dropping out from school, failure in what they're doing in life. And then on average, 1 year prior to the onset of frank psychosis, when we can diagnose schizophrenia, you have what we call attenuated psychotic symptoms. In other words, they're not fully developed delusions or fully developed hallucinations, but some odd thinking, almost delusions, overvalued ideas. I think someone's trying to kill me. I'm not sure. It may not, so it's not delusional, but it's really bothering me. I think it might well be true. So subthreshold positive symptoms. Now, what you can see is the 6 dimensions that we discussed with regards to the dimensions of schizophrenia and other psychotic illnesses. You can see in terms of the evolution of the prodrome as it develops until you finally have schizophrenia. Here, you see these different symptom domains manifested. So and the last thing I would say about the prodrome is I mentioned earlier that the average IQ of persons with schizophrenia is about 80 to 84, about 1 standard deviation on average across the domains. When does this impairment occur? And as you can see in this slide graphic, premorbid, prodrome, first episode, and chronic. And you can see most of the cognitive decline occurs very, very early in the illness. In fact, a lot of it prior to the very first episode of psychosis. So that's something that we need to keep in mind as we come to what changes were made in DSM-5. So let's kind of think about some key changes. And I want to draw your attention to 4 basic important changes that were made. The first important change that was made was a description of those 6 symptom domains and their application to diagnosis, first of psychosis. So essentially, if you ask someone to define psychosis, and you really begin listing all the definitions that are used, you'll see there's some variation. And a lot of the variation has to do with the fact that, in fact, if you think about psychosis, there are those 6 domains, as we point out: positive symptoms, disorganization, motor symptoms, negative symptoms, cognitive symptoms, mood symptoms. If you have any of those, does that define psychosis? And in DSM-5, looking at all the data, and thinking about the clinical application, we said, well, we need to distinguish the core features of psychosis from the accompanying features of psychosis. That is, if you say someone has psychosis, basically they must have at least one of the 3 core features: delusions or hallucinations or severe disorganization of speech. If you don't have any of those, if you don't have delusions, hallucinations, or severe disorganization of speech at any point in your history, you do not have psychosis. You may have any other serious psychiatric condition that needs attention, but it is not psychosis. You must have one of those 3 core features to say that you have psychosis. On the other hand, if you have any of those 3 features, any or all of those 3 features, you clearly have psychosis. Now, having said that, psychotic disorders also have very important accompanying features. Motor symptoms, catatonia being the most extreme example, disorganization, both of behavior and thinking, negative symptoms, cognitive deficits, mood symptoms. And so, as you think about it, how you differentiate between different psychotic disorders depends on the combination of what accompanying features are there. The accompanying features are also very important in terms of thinking about how best to help people, because they also need to improve. They also need to be targeted when you're working with patients. But an important distinction between core features of psychosis and accompanying features of psychosis. And that applies to all psychotic disorders. And so a second thing to keep in mind, getting back to these six domains. So in DSM-5, schizophrenia, as also other psychotic disorders, attention was drawn to the importance of recognizing the six domains. Now, we've known for a long time that persons with schizophrenia look different. There's a lot of heterogeneity in the illness. And we've tried to explain this heterogeneity by subtypes and things of that sort. And that's not really been useful at all. It's not been helpful to us. And so this is what we need to understand in terms of understanding the variations in the expression of schizophrenia across individuals that will help us individualize treatment. Now, one of the things that we know from all of medicine is it's good to know what the clinical features are, but if you can't assess them reliably, then the clinical application becomes a little weaker. So it's like saying, it's important to know if your blood pressure is elevated or not. Is it increased or not increased? Well, that's good. That's an important thing to know. But if you can't measure blood pressure, then the value of that clinical information is diminished. What that means really is that we need to have tools to measure. And this is a simple tool that was developed in DSM-5. It's in section 3 of the DSM-5 manual. A very simple scale, 8 items on the scale, each item measured on a 0 to 4 scale. What is 0? 0 means that particular item is not present, clearly not present. 2 to 4, it's clearly present. 1, I can't really tell. It seems kind of present, but I'm not 100% sure. But 2 to 4, it's clearly present, mild, clearly present, moderate, clearly present, severe. And if you look at the manual in section 3, DSM-5, you'll see anchors for them. Even more importantly, as you begin using this instrument, you will develop reliability. And so as you're treating patients, you will be able to more reliably measure change in each of these domains. And as you can see, the 8 items that you have allow you to see what's happening to positive symptoms, hallucinations, delusions, disorganization, motor symptoms, negative symptoms, cognitive symptoms, and mood symptoms, again, as 2 items, depression and mania, because you've got to measure them separately. And you can individualize treatment. You can make treatment changes, modifications, based on what's happening to each of these domains. It's possible for one domain to be improving. That's positive symptoms, hallucinations, delusions are getting better, while depression is getting worse, or negative symptoms are getting worse. And so you can individualize treatment. We don't have time to really discuss the clinical application, but I want to draw your attention to this important tool that's available in DSM-5, and as to how to why it's important to apply it. It'll help you treat your patients more precisely. It will help you. We use it routinely in our clinical practice in my department whenever we're treating any psychotic disorders. It helps us individualize treatment. It helps us target specific dimensions of treatment, and really has made a difference. There are lots of studies looking at its reliability, validity, clinical application, but we can discuss those details at a later time. So, key changes in DSM-5, no more subtypes. So we've had these for more than 100 years, no more subtypes of schizophrenia, not of clinical value. But in terms of understanding the heterogeneity, as also the implications of that for diagnosis, we've emphasized the dimensions of psychosis, particularly, with regard to schizophrenia. We've discussed them. We don't have the time to discuss it with regard to other psychotic disorders, but that's an important aspect. And in addition to that, we have a specific tool, a simple tool. It really doesn't take more than a few minutes to administer this tool. So it's not a huge rating scale, 2 hours, 3 hours, that kind of thing. It's a simple tool, and we have this tool now to allow us to measure these different dimensions. The criteria for schizoaffective disorder have been made much tighter to give it more better definition and better utility. The condition of attenuated psychosis syndrome for the attenuated psychotic symptoms that on average precede onset of psychosis by a year has been added. And very important, this is not a condition you treat with antipsychotics. There are other treatment implications of this. And again, maybe we can discuss it in the Q&A should that come up. So with that, let's actually think about, well, okay, good. Now that these changes are interesting, they're important. But again, I don't apply criteria strictly. I mean, of course, I've got to give a diagnosis for purposes of insurance documentation. But really, does it really matter? Well, a proper diagnosis of schizophrenia does matter. There are very important implications in terms of understanding the condition, helping persons with the condition, how to individualize treatment, how to help each person lead the most productive, meaningful life that he or she can. So there are very important implications for diagnosing schizophrenia correctly. And to do that, know the criteria. They're fairly simple, fairly straightforward, and then apply them strictly. Don't be loosey-goosey about applying clinical criteria. And finally, avoid common mistakes that are made. And I want to end with some of the common mistakes that are made. You're seeing less and less of this, but you still see, particularly some older generation psychiatrists, if you will, I can smell schizophrenia. There's this precox feeling, there's this feeling I have that, this is schizophrenia. I can smell it. No, don't smell schizophrenia. Look at the clinical presentation and apply the criteria strictly. 2, folks are not aware of the changes that have been made in our understanding of schizophrenia and how that's impacted how you diagnose schizophrenia. There's a much greater emphasis on positive symptoms. And so you have to have at least one core psychotic symptom present. The accessory symptoms are important, very important. And it's important to measure, understand how they're impacting the life of a person with schizophrenia. But there's a much greater emphasis on positive symptoms. And we have a much better recognition of how that it's a very heterogeneous illness. It varies across different persons with schizophrenia, and the dimensions allow you to get a better handle on understanding this heterogeneity. So essentially, this is the mistake that is made. A third mistake that we often make, we get, over the last, as I mentioned to you, I've been a practicing psychiatrist for about 40 years. And I've probably in the course of my career treated about, over 20,000 patients with schizophrenia. And this is probably an underestimate. And I've also trained literally hundreds of physicians. And one of the things that I've noticed and overseen large systems of care, one of the things I've seen is phenomenologically, people are less rigorous. Is this really a delusion or is this an overvalued idea? Well, if it's a delusion, then it's psychosis. If it's an overvalued idea, that's not psychosis. Similarly, with regard to the core psychotic criteria, one of which is delusion, one of which is hallucination, and one of which is severe disorganization, and we look at severe disorganization of thinking, it's important to make sure that that particular core feature is present, because otherwise you can't diagnose psychosis and you can't diagnose schizophrenia, which is a key psychotic illness, if you will. And lastly, there are some who are so frustrated with the inadequacies in our diagnostic system that they're jumping ahead. Let's use biomarkers, let's use biotypes, things of that sort. and we're not there yet. We'll get there, but we are not there yet. So, with that, in closing, uh, this is what we've shared: the importance of multiple psychopathological dimensions, very, very important, and a tool, a simple tool to measure it. At a different time, we can talk about how to apply the tool and what difference that makes to treatment choices. We can discuss a number of clinical patient scenarios, and I can share with you a number of situations where this has been critical. Using this tool has been critical in enabling my team to make the best clinical decision, treatment choice for this particular patient. Now, ICD-11, as you know, also ICD-11 came out a couple of years ago, and ICD-11, lots and lots of similarities to DSM-5. And it's not an accident because the chair of the ICD-11 psychosis group, Wolfgang Gabel, who is also a member of our DSM-5 work group on psychosis. And so some differences, but a number of some, I mean, mainly harmonized. And of course, recognizing the clinical course and the importance of the prodrome with regard to modifying how persons with schizophrenia go on to do, we've added this condition of attenuated psychosis syndrome. So, final take home messages: important changes in DSM-5, which basically encapsulate some of the key understandings that we have about the nature of the illness. Uh, Heterogeneity, illness dimensions, importance of illness dimensions, which helps us understand what's happening with patients much better. And measurement of these dimensions really is important, very, very important in helping us optimally individualize treatment. Pay attention to the distinction between core features and accompanying features. And we've not had time to discuss the implications of each of these across different psychotic disorders, but that's an important change. And with attenuated psychosis syndrome, there are specific interventions. Again, not antipsychotics. Just because you say attenuated psychosis doesn't mean use an antipsychotic. No, there are other interventions, and we're in the process, across the world, in developing more specific interventions, if you will, at this early stage in the illness. With that, shukriya. It's been a pleasure. We will have time for questions. And so I want to thank you all for your attention and looking forward to the Q&A.